Hi, welcome to Iron's Health Talk with Dr. Akram. And I'm Akram. In this program, we'll be talking about all kinds of different health issues with different experts in the field. Today, we will be talking about ischemic heart disease and coronary artery bypass grafting. So sit back, relax, and enjoy your time with us. Despite increasing survival, cardiovascular disease remains the primary cause of death worldwide, with an estimated 7.4 million annual deaths. The main symptoms of ischemic heart disease is chest pain, angina pectoris, most often caused by blockage of a coronary artery. The aim of coronary artery bypass surgery is revascularization achieved by surgically grafting harvested arteries or veins distal to the coronary lesion, restoring blood flow to the heart muscle. Ischemic heart disease was first described in the 18th century by Giovanni Batti Morgagni and Frederick Hoffman, who identified anginal syndromes and reduced coronary blood flow, respectively. It is estimated that 60% of the world's cardiovascular disease burden will occur in the South Asian subcontinent, despite only accounting for 20% of the world population. This may be secondary to a combination of genetic predisposition and environmental factors. Organizations such as the Indian Heart Association are working with the World Heart Federation to raise awareness about this issue. First of all, let's look at what is ischemic heart disease, its symptoms, signs, how does it affect our lives, and what kind of remedies we got in store. Let's welcome our special guests. Three of them joining today. Dr. Shakil Farid, joining from Oxford. He's a consultant cardiac surgeon in Oxford, and he is a director of FRCS cardiothoracic courses. And also Dr. Vivek Shrivastava, also joining from Oxford. He also works as a consultant cardiac surgeon at Oxford University Hospitals. And Dr. Chowdhury, our son from USA. He is a clinical professor of medicine in University of Nevada, Las Vegas, School of Medicine. And he is also director of cardiac catheterization laboratories, University Medical Center. Hello, welcome to our program.
Hello, thanks for the invitation.
Shakil, how are you doing?
Fine, thank you.
Vivek?
Thank you, yes, thank you for having me here.
And Asan?
Yeah.
Hi, how are you?
Oh, very good, very good. Nice to see you. How is USA?
USA is good. We are in Las Vegas. This is actually midday. And greetings from the USA.
Is it warm there in USA? Is Las Vegas, I suppose, yeah, it sounds like a nice holiday destination for me.
It is warm, but COVID-19 is in full speed here. We are seeing a surge.
Oh dear.
But your patients are in best hands. I know we got the best specialists in our show today. But anyway, and also I want to welcome my special guest, Hargo, who is here in our studio with us. She got so much interest in the program and she wrote to me about, you want to be in the show?
Yeah.
Can you tell a little bit about you, Hargo?
I'm 15. I was wondering maybe if in the future I would like to do something related to medicine. So I thought it would be quite interesting to actually learn about it.
And you got lots of questions as well. I can
Yeah.
see you got lots of papers. That's interesting, Hargo. Thank you very much for joining us. And
You should become a heart surgeon in future. Okay?
there you go.
Good female heart surgeons in the world.
That's a good idea. Here we go. Yeah.
Don't become a cardiologist.
By the way, Shakil, the head of surgery here in my hospital is Dr. Queen Ficus. She's a female surgeon.
She's a
There you
female
go.
surgeon. Oh, excellent. All right. That sounds good. So here we go. We got something to look forward, yeah? Okay. This is a live program. So call us on 0203 515 5788 if you have questions or suggestions. Or write to us healthtalk@intv.co.uk. And you can also follow us on Twitter and Facebook, Iron Health Talk with Dr. Akram. And of course, you can watch us on Facebook Live, intv.co.uk. Okay, let's go back. Vivek, how is Oxford?
Oxford is good. I think I have my good colleague here as well, and it's always better when he's around. No, Oxford is good. Thankfully, we are picking up on what we are able to do just now, so that has been a bit of a problem in the last few days, but hopefully we are looking to normalizing our activities. So thank you.
Thanks a lot, guys, joining with us today, and especially Shakil and Alsan. Both of them are on call for the hospital, and they are in the program because we planned it and we couldn't change it. And I'm really grateful for you, both of you, being with us. And hopefully nobody is going to call you during the program, so we can conduct the program. Anyway, that'll be great. Okay, let's go back.
I can ask my good colleague, Mr. Vivek Srivastava, to cover me.
Sorry, I'm on the program. you are by yourself, sir.
Okay, let's go back. Alsan, can you say a little bit about ischemic heart disease? What is this about?
So when you talk about the, I would rather say coronary artery disease, the one that we see the majority of the deaths are due to, is actually the formation of the plaque buildup in the coronary artery that supplies the heart muscle. So these plaques can compromise the flow, and that can lead to symptoms like chest pain on exertion. So demand supply mismatch. In many patients, it can be just plaques sitting there is no flow compromise, and there is no symptom. So it can be asymptomatic, and it can be symptoms with exertion because of the plaque buildup and flow compromise with demand supply. But uniquely, as we all know, there is another problem with the plaque, that these plaques can rupture or can get erosion and can activate the clotting system and the platelet activation and present as what we call acute coronary syndrome, meaning heart attack in different forms.
Okay.
So,
What we're talking about here is the blood vessel which is supplying to the heart muscles itself, isn't it?
correct.
Exactly. I just want to make it clear for our audience. So these are the special vessels which supply blood to the heart muscle. Hanko, you said you read a little bit about that.
Yeah.
Can you tell a little bit about it? Okay, from your perspective.
Well, I read a bit about the vessels,
Yeah.
and it's like when there's build-up, the blood might not be able to reach the heart properly, so it might not be able to function and could lead to a heart attack.
So it can lead to heart attacks. That's what we're going for. Is that right?
Yes,
Okay.
but it is important to realize that the presentation can be in a stable condition. That means the patient has some chest pain, and there are some atypical symptoms. Particularly, we see that in the females, fatigue, shortness of breath, and these are like stable over time. But it can also present as sudden onset of chest pain, short of breath because of the plaque instability.
So you're telling somebody who's... Yeah.
At the same time, we want to warn the patients and population, particularly in South Asians, that many plaques can be asymptomatic. Those who have risk factors, and this is the preventive side, if we think about the pathophysiology of the coronary disease, many can be asymptomatic with plaques. But if I have risk factors, I need to be careful about the risk minimization so that I don't end up with plaque buildup and angina, or for that matter, end up in heart attack.
So what you're telling is somebody who is normal, who's leading a normal life, suddenly get chest pain, and suddenly you realize that his heart has been, these vessels been blocked for a while. Is that right?
Correct.
Okay. And Shakil, how common you see patients being referred to you for heart surgery or for this kind of surgery?
Yeah, so specifically related to ischemic heart disease, we do see quite frequently patients being referred for surgery. Now, if you think about all the patients who undergo angiogram, around 30 to 40% of them end up needing some form of treatment. Of those 30 to 40%, about 80 to 90% undergoes angioplasty, and 10 to 20% comes for surgery. Now, people who have triple vessel disease, especially patients with diabetes or reduced heart function, or patients who have disease in the left main stem, we say, which is like near the origin of the artery, coronary artery, those patients actually usually come for heart surgery. And being a big center, we do see quite a lot of patients, like every week we get referred quite a lot of patients for coronary artery bypass grafting.
So 20% of them being referred with chest pain might end up with some kind of heart surgery. Is that right?
No, so the number is not quite right. So if
Okay.
you have symptoms of heart disease, you end up needing an angiogram. Out of those 100%, around 30 to 40% need some form of treatment, whether it's stenting or surgery. Out of those 40%, around 70 to 80% undergo some form of stenting, only 10 to 20%. So if you look
Okay.
at the whole spectrum, I would say around 4 or 5% patients come for surgery.
Come for surgery. But
Yes.
still there are lots of other procedures we could do before they go to surgery, isn't it?
Yeah,
As a first
absolutely,
step.
yeah.
As a first step. Okay. I was just wondering, can one of you explain a little bit about this blood supply to this heart, like in quick format, so we could make our viewers understand what we're talking about?
So,
Maybe.
Vivek, do you want to do it?
Yeah, maybe I can do that. That's fine. Sorry, your guest has read up about the heart and conditions and probably read up about blood supply as well. But basically, heart, like any other muscle, is supplied by arteries that supply the pure blood and help the heart muscle function. The arteries are quite small, as you can imagine, so probably about at most 2 millimeters across, and it doesn't take a lot of blockage or obstruction in there to affect how the blood flows through there. So these are arteries that come off the aorta, which is the big artery, the biggest artery coming out from the heart to supply blood to the rest of the body. There are two arteries basically, one on the left side, one on the right side. And the left-sided artery is usually the most dominant in most people. So dominant, I mean, it is responsible for supplying most of the heart muscle in about 85% of the people. But it is only a short artery, and then it divides into two branches. One for the main pumping chamber, the left-sided heart, as we call it, the left ventricle, and the partition in the heart. And there is one branch that goes to the back of the heart. So the left side is covered by this two big branches. And then there is a right-sided artery, which supplies the right side of the heart and the bottom of the heart part. But between them, each of them is important because they are all responsible for supplying their own areas of the heart muscle. And if there is a sudden heart attack, then, or if it's a very significant or sudden event, then the other arteries are not able to cover for other arteries, and that results in damage to the heart muscle. But if it's a slow, gradual process, then sometimes we see that little channels develop within the heart muscle that cover for other areas, and people can go on for a long time. And that is why, as Dr. Hassan explained earlier, symptoms can suddenly appear, but the disease process has obviously gone on for several years, but because the heart has adjusted itself to it, it's kind of not evident immediately. Does that make sense?
Thanks, Vivek. Yeah, that's excellent. We have a caller actually. Let's get the caller as well to join us the program. Hello. 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 Do you hear us? Welcome to Iron's Health Talk with Dr. Akram. I think there must be a problem with call. Okay, let's continue with the program. What are the common symptoms of patients who seek help with you, Vivek?
Yes, that is the interesting thing about the heart condition that we are talking about, ischemic heart disease. And as Dr. Hassan has already elaborated in quite good detail, there's a whole range of symptoms that people present with. Okay. Classically, what we describe as crushing chest pain or very severe chest pain is probably true only for a small minority of patients, and public need to be aware that that may be one presentation, and that's certainly indicative of really bad heart attack happening or really significant affliction of the blood supply. But more commonly, people may experience just heartburn-like symptoms and are treated for reflux or treated as just heartburn and treated with antacids. But in effect, it may be just a reflection of lack of blood supply to the heart muscle. And people just need to be aware that if it is coming on with effort and it is not going away with just rest and usual antacid treatment, then it is something to be aware of and be actually persistent with your own doctor to kind of investigate it further. That's one way. The other presentation that people can have is, a lot of our, particularly South Asian population, are diabetic, and they may not even experience any symptoms until a proper major heart attack happens. But also, if the heart muscle has been damaged or has been suffering for some time, it may only present as some breathlessness on exertion or more than usual effort. People may notice that they are feeling more breathless and not able to do what they were able to do, let's say, last year. So these are things that people should just be aware of, and because it's such a high incidence of ischemic heart disease, and especially our subgroup of population, it is just something that people should be vigilant for and be actually investigating for it if required. And then, of course, if it's a major heart attack, the pain usually will not subside, and people should seek medical help.
Ahsan, are these conditions reversible? And can ischemic heart disease preventable?
Okay, so let me address your second question first. The clinical impact comes from the plaque burden, as you can imagine. And the more the plaque, the more is the flow compromise, and the more the plaque, there is a potential that the plaque can undergo a process called plaque rupture, plaque erosion, plaque fissuring, and present as what I call this acute ischemic. Ischemia means lack of blood supply. Acute means sudden. Acute ischemic scenario or chronic ischemic scenario. But if it is chronic, you have time to evaluate, right? But in the acute, you need to work very fast to save lives. We don't want to go to the acute situation. And therefore, if someone has the risk factors that we know from, for example, from the Framingham study, that high blood pressure, diabetes, cholesterol high, the obesity, and then all these high cholesterol level, particularly the LDL fraction high, all these contribute. So if we can address this and minimize, these are all modifiable risk factors. We cannot do anything about the non-modifiable risk factors, which is the genetics, which is the family history. But what we can do, and one important thing that I did not mention is the smoking. Very key that we address this and then we modify the disease, the risk factors, so that the disease does not come back and take the lives. So that's the preventive side. The interesting question that you asked me, can it be reversed? So plaque, when we see in the artery, and that gives the plaque burden, and the more the plaque, there is the core of the plaque. If it is soft, it becomes vulnerable for plaque rupture and then activation of the clotting system and the platelet activation and full blockage of the artery and then we see the full-blown heart attack. But if you think about a therapy that regresses the plaque, that will be unique, right? We use the statins, and now we know that the statins actually stabilizes the plaque. So if I have plaque, it probably would be stabilized so it would not rupture or would not go through the erosion. So at least I would have less chance of an acute ischemic event. That's one thing. And also, another interesting thing about the reversal, there's actually a study called reversal. Dr. Steve Nissen from Cleveland Clinic was the PI, principal investigator, and they showed that with aggressive statin therapy, if you do the intravascular ultrasound and assess the plaque volume, you actually see there is a regression of the plaque. So we go for the bad cholesterol particle called LDL and lower it down and down, go down below 70, even 50, then we may see some regression of the plaque. And remember, if the plaque volume is decreased even 10%, that will give you a higher lumen area. So even if I don't get a regression, even if I don't get a reversal, at least we can get stabilization of the plaque. So preventive measures are very important. Risk factors are very important. Understanding the pathophysiology is important. And now we are seeing from even the UK studies, if you look at the CT angiograms, we can see the plaque without doing an angiogram, because coronary angiogram, the invasive one, and Shakil and Vivek, you guys know, this is basically luminogram. It gives us the idea about the lumen, but the story of the coronary disease is in the wall of the artery. The CT angiogram is giving us insights about what's in the walls. So good questions, and yes, we can do things that can prevent.
Okay. Shakil boy, can you tell us, is a surgery is the answer, or what else can we do?
So, if you have coronary artery disease, there are three ways of managing the patient. So people who have minimal symptoms, who have single vessel disease, who have non-critical disease, however a little bit of disease, they can perfectly be managed by giving medical treatment, especially elderly patients who do not have much symptoms. It's perfectly all right to treat them with medical therapy. As Dr. Chaudhary has said, you can give them aspirins, you can give them statins, you can give them drugs to slow down the heart rate a bit, and their outcome is pretty good. Then the next thing is stenting. Stenting is done in patients who have single or double vessel disease and which are in geographically good position. It's not near the origin of the artery or the main stem of the artery. They're perfectly all right to have stents. And surgery is only reserved for people who have very critical coronary artery disease that is not amenable to stenting, or patients who have diabetes, who have multivessel disease, or people who have very critical disease in critical vessel, which is quite risky to do stenting or something. Those patients actually have good outcome with surgery. So we do surgery for two reasons. One is to give survival benefit, another one is to improve the symptoms. So it's really important to realize that there are different ways of treating ischemic heart disease. It's not only surgery. And most of the patients do very well after surgery. We have seen the long-term results, which are fantastic. I mean, in UK alone, if you look at the data, only slightly over 1% patient comes back for a repeat revascularization following coronary artery bypass grafting. If you look at a long-term result, the 5-year survival, the 10-year survival, they are excellent. So, bypass surgery is pretty safe now. It can be done with less than 1% mortality, with very low risk of stroke, wound infection, things like that. So, it's almost like having a routine operation. Our patients come on the day of the surgery, they get discharged. Most of the patients get discharged on day 4 or day 5. It's only the really sick patients who need extended stay in the hospital. So yes, I mean, there are different ways of dealing with ischemic heart disease.
Thank you very much, Shakil. Today we are talking about ischemic heart disease and what we can do for this, especially the surgical management. So far we have talked a little bit about ischemic heart disease. What is it? What are the symptoms? What are we going to look for? And coronary artery bypass. And on our studio, I have a special guest here who's Hogo, and who she's a student, and 3 other guests joined from Skype. They came, it's Hassan who came from USA, and 2 consultants, cardiac surgeons joined from Oxford. That's Shakil and Vivek. They are all with us, and today, so far we have talked a little bit about coronary artery disease and what we could do, the initial bit. Now we're going to go to the treatment next. And if anyone joined today in this program at this time, please be with us, and we're going to talk more about it. And first of all, I'm going to take a caller, and there's a caller online. Hello, sir.
Hello, good evening.
Good evening. What's your name, sir?
It's Mahmoud Rahman.
Mahmoud Rahman. Yeah, okay. Thank you very much for calling us. Where are you calling from? Which part of are you from?
I'm calling from Bath.
Are you calling from Bath? That's excellent.
Yes.
What do you do generally? Are you a
I'm
medical?
retired now. I'm a university lecturer.
Are you retired?
I'm a chemical engineer. I'm retired.
Are you retired university lecturer? Okay.
Yes.
What is your question, sir?
I had a heart bypass operation in 1995 when I was only 40 something, and there was 4 bypass grafts were done. The last angiography I had, 2018, I went to local hospital with chest pain, and they thought I had a heart attack. So I was sent to Bristol Royal Infirmary, and they said there's no heart attack. But anyway, they did the angiography. Then they found all the 4 bypass grafts are still intact. So that's very good news. Now, while there, they increased my statin to from 40 to 80 milligrams. Now, it is, I think we found out through my cardiologist, Dr. Mansfield, in Royal United Hospital, Bath, that the combination of diltiazem, the other medication I have, with statin causes some difficulties, but which is not very clear. I have some symptoms like hot flashes, my head getting hot, some other symptoms, peculiar symptoms like getting, feeling blood, vision, this sort of thing. Now, I have then, with consultation with my cardiologist, reduced the statin to 20 milligram now. Now, with your discussion, Dr. Chaudhary, the way he discussed, the higher doses of statin looks like helps to, if there is any plaque build-up. So, my main medication is diltiazem 90 milligram twice daily, and aspirin. I take 60 milligram isozorvite mononitrate, and these are the main heart medications. If you could advise me if I need to increase the statin or any other medication I need to keep me well for the next.
Thank you very much, sir. That's quite important and quite interesting question. I think it's Ahsan Chowdhury it must be the best person to answer that.
Let me tell you that in your case, I do agree with your cardiologist that the goal, if we can achieve the LDL, the target below 70, and that will be probably, you know that from the Prove It trial that it is better. And if you look at the LDL level and the event rate, the lower the LDL level, the event rate is lower. Now, in your case, question is how much dose is good? Whatever dose you need to achieve that is probably the goal. But we, the South Asians, we have a problem. And with our genetic constitution of the enzyme, that metabolizes the statin, that is the cytochrome P450 system. I did my PhD from Southampton University, and that was my life, that whenever you challenge a substrate that uses that enzyme, the enzyme expression is a problem, and that because it's less, and therefore the side effects with a similar dose is going to be higher for South Asians compared to Caucasians. So the trick that we can do, try the lower dose, 40 milligram, see where is the LDL, or you can do a combination with ezetimibe and then see whether the LDL goes down. It sounds like you are not someone who is intolerant to statin, because intolerant patients, they cannot take any statin. But you are able to take, but the higher dose can give you problem. And diltiazem, for example, is a drug that can cause the interaction so that it is also a inhibitor for the enzyme. So you may have a pharmacokinetic drug interaction with the statin giving more intolerance or side effects with the same dose when you are using diltiazem. There is a potential. Now, in the totally intolerant statin, we use the PCSK9 inhibitors, which is totally different mechanism, and you probably don't need that. I would try this combination first, but I would discuss with your cardiologist. I'm not your cardiologist, but that's the strategy I will take.
Thank you very much, Ahsan. Are you happy with the answer, sir? Thank you very much. I think we dropped the caller. Thank you very much for calling us. Anyway, Hugo, you wanted to ask some questions, no?
Yeah, I've got a question for Dr. Vivek, if that's possible.
Yes.
Are there any occasions where you would refuse surgery, and why?
Yes. So I think if you look at angiograms, and that is how currently traditionally decisions are made about who can have stents and who can have a bypass operation, the decisions are based on what's called anatomical basis. So we look at the angiograms, and the coronary arteries may seem very good to do bypasses for, or they may be quite diffusely diseased, and that is one of the reasons why we may choose not to, because the possibility of getting them benefit is quite low, and putting them through even though it has become a lot safer, the operation still carries a risk. And it may be that the risk is actually far more. So the two things that we have to weigh out is what benefits they stand to gain and what risk they face. So the risk can come from the procedure itself, or the risk can come from what patients are like. Patients may have various comorbidities, and there are patients who the risk may not be 1 in 100 chance as we quote normally, and the risk may be much higher because they have other problems like lung conditions, they may have kidney problems, they may have liver problems, and various other conditions that may cause them to be a much higher risk person for a standard operation. The procedure itself is probably similar for everyone, but their ability to withstand that operation may not be the same. So in that case, we have to make a careful assessment, and if whether the benefit they stand to gain out of all this is really worth taking and really worth exploring. So that is one scenario where we may say, no, unfortunately, bypass is a very high risk option for you, and you may have to go either for stents as probably equivalent, or maybe a better considering the circumstances, or continue with medications. And it all depends on how the patient is. Sorry, I'll keep it brief, but we could.
And Vivek, that we are calling the heart team approach now.
Absolutely.
We are in the same team.
Absolutely.
In the same team. That's good.
That's the important thing, isn't it?
So you got the ideas, and so it's
Yeah.
like it's not everyone who's been referred to these cardiac surgeons get the surgery,
Yeah.
but sometimes the cardiac surgeons or anesthetists can refuse because the patient is maybe not fit for the operation, or the operation is not possible because the block or the plaque is in funny place and they can't operate on it.
Yeah.
So do you want to ask some more questions?
I've got a question, but it's a bit different.
Okay, you can ask it.
Are there any other minorities that would possibly be at a high risk of getting the disease? as well.
So we talked about so far the South Asians are
Yeah.
vulnerable for this heart disease, and Hugo's asking whether if are there any other population or any other minorities are in higher risk. What about
I can tell you the U.S. experience because we have the Mexican American population, we have the Indian American populations, and what we know, and I see the same trend that Dr. Salim Yusuf, who was in Oxford before and then moved to Canada, and his studies, he showed that all these risk factors, the traditional risk factors that we know about that relate to the coronary artery disease, aside from the genetics part, if we get that early in our life, then we encountered this problem, the coronary artery disease, earlier and also in more severe form. And we see that trend in every minority communities. We see that in Indian Americans with diabetes, obesity. We see that in Spanish population in the US. And it is like, to me, no more a surprise that when the risk factors come into play and appear early and we don't take any preventive measures, it's going to play out the same way.
Yeah, Shakil, do you see any difference in the Middle Eastern population? Do they have any difference in?
Yeah, I think the Middle Eastern population has have quite nasty disease as well. From my experience, I totally agree with what Dr. Chaudhary has said. I would like to add that your socio-economic condition does play a role as well, because it has been seen that in poor, deprived areas, the incidence of heart disease is quite high, because a lot of them are not aware about their health needs. They don't go to the doctors for regular checkups. A lot of them live on fast food because it's cheap. There's lack of exercise, lack of education, and the incidence of diabetes, obesity is very high in those populations. So as Dr. Chaudhary has said, that's a similar experience in UK as well. Fortunately, we work in a very good part of the country, which is Oxfordshire, and you can actually see a distinct difference between the demographics of the patients we get from Oxfordshire itself and from outside Oxford, like people who are coming from big cities like London, very crowded areas. So I think this is something which is really important.
What kind of preparation you make before surgery, Shakil?
So before surgery, one is preparation of the patient, obviously, and preparation of the surgeon. So preparation of the patient is you need to make sure that the patient is fit for an operation. So how do you determine that? So you take a thorough history to see whether there are any major comorbidities. Then you perform some clinical examinations, and finally you do some tests. So fortunately, in most of the cardiac centers in the world, there are pre-op assessment nurses who actually make sure that all the T's are crossed and I's are dotted. So basically, the patients have blood tests, patients have chest X-ray, then ultrasound of the heart, which is known as echocardiogram. And if any of these investigations pick up anything bad, then we do further investigations like CT scans or any specific tests that's needed. Finally, it gives us an idea about the risk profile of the patient, and we use a risk scoring system, which is known as the Euroscore. And when you enter all the data that you have got from the clinical exam and investigation of the patient, it gives you a rough estimation of the risk. For example, if someone is under 60, coming for a bypass operation, doesn't have any history of anything at all, no major comorbidities, his risk of death is around 0.5% according to the Euroscore. The same individual, if he has other problems like diabetic, on insulin, has lung disease for which he's on inhalers, and he has any other major problem like neurological problems, his risk profile goes up, like his risk of death can be 4 to 5%. So, these are really important to assess the patients properly. And when I say, the other thing I said about preparation for the surgeon, I think it's really important to be focused before you are going in for a surgery. So personally, what I do is, when I'm scrubbing for the operation, I try to rehearse the operation in my head, in my brain. And I find it quite useful because you are quite focused, and it's important to get a good night's sleep, eat properly. These are all important things. For you, it's just another operation, but the person who is having the operation, it's his life at stake. You have to think about the long-term and the short-term outcome of that patient. So yes, I think it's really important for the surgeon to be prepared for the operation as well.
That's quite
Very well put, Shakil. Very well. Yeah.
That's quite interesting. That's quite interesting. Yeah. Let's talk. Do you have any more questions you want to ask? You can ask Vivek anything.
Oh yeah. Okay. So what exactly would you do to the artery during the surgery?
Sorry, is that for me?
Yeah, he's asking Vivek.
Okay. Right. Okay. So yeah, like I was describing earlier, the arteries are quite fine. So most surgeons would use magnifying glass. So when we are in theater, now techniques may vary, but effectively what a bypass operation is doing is creating a bypass route for blood flow to flow around the obstruction or the narrowing that is in the artery. So we look at these arteries, we assess where, based on the angiogram, where the bypass needs to go so the downstream blood supply is clear. And that's where we then open up this artery, tiny incision, probably about 4 millimeters, 5 millimeter long incision there, which is a
so
cut
you need
in the
to
artery.
open into the chest before that, isn't it?
Yes, of course. Yes.
Okay.
So most bypass operations would be done through the chest. And through the middle of the breastbone, the sternum. Some surgeons do use the spaces between the ribs to go get into the chest. And then we most commonly, what blood supplies we use to divert to the heart are the mammary artery, which is the arteries that run along the side, the breastbones on the sternum side. Which is the left mammary artery is the most commonly used conduit. Conduit meaning something that provides blood supply. And then the next commonly used is the vein from the legs, which is the saphenous veins. And the leg has a dual system, so the long saphenous system can be used for that. Then there are other things like the forearm arteries and the right-sided mammary artery can be used as well. But these are basically ways that can be used to provide blood supply down the stream. So yeah, at surgery, we would get to the heart. Most people would arrest the heart. We use a bypass machine to support circulation during that time.
So during the operation, you stop the heart physically?
Yes.
Okay.
Well, most people would do. I think that's the most common way to do the operation. Although if you go to India and if you go to Bangladesh, people are very skilled in doing off-pump operations, which is also done in the UK, also done in the US, but by a far lower number of surgeons, where the heart is kept beating, but it can be positioned and it can be stabilized using special devices. And once we have access to those arteries, we open up the artery and we use very fine stitches, very fine sutures to attach one end of the artery or vein that we are using as a conduit. And then the other end is either attached naturally, as in the case of the left mammary artery, it already has a natural supply which is not interrupted, so it's a different pathway for blood to flow around. Or if it's a vein or another artery or a different kind of conduit that we are using, then that has to be attached to the aorta, which is the big artery leaving the heart with the pure blood supply. Then once we're done with that, we make sure that there isn't any bleeding, make sure the heart is functioning okay, make sure the bypasses are working all right in terms of what they're meant to do, in terms of providing the blood supply. And then we close the chest, and that's the end of the operation. But it's the start of a journey for recovery period for the patient thereon. As you can imagine, it's a big operation to get through. But that's what we do in theater, and that takes somewhere between 3 hours. Most operations would take about 3 hours, some take longer, 4 hours. Yeah, that's about it.
I want to ask a special question this is for Shakil. While you are operating, you stop the heart. How do you supply blood to the other part of the body during that operation? What do you do?
Yes, there is a solution we call it cardioplegia solution. So basically it gives nutrition to the heart, and it also gives some electrolytes which stops the heart, like it's very high in potassium. And some people, what they do is they reduce the temperature as well. So like personally, normally a normal human being would have a temperature of 36.5. But when I operate, I reduce the temperature to 32 degrees. Some people reduce to 34 degrees. So you are protecting the heart in many ways. You're reducing the temperature, which reduces the metabolic demand of the heart. And then you're giving some metabolites to the heart every 15 to 20 minutes. And also you are giving some electrolytes to keep it still. So when the heart is cold, it's not beating, the oxygen consumption of the heart is low, it needs less nutrition. So this is how we do the operation. And if you look statistically, I think only 10 to 15% of surgeons around the world do beating heart surgery in the whole world. Whereas if you go to countries like Bangladesh and India, it's slightly different, as my colleague has said. The incidence of off-pump beating heart surgery is more in those situations, in those countries.
And you have a special pump which supplies blood to the brain and other part of the body during the operation.
It's a heart-lung machine. So basically, when the heart is stopped, the lung is also stopped. The heart-lung machine does the function of the heart. So it has a pump. At the same time, it has an oxygenator. So it works as an artificial heart-lung. And it's safe to do operations like that. You can stop the heart for a long time by giving nutrition, doing all the right things. You can keep it alive, and you can the heart starts to beat as soon as you restore the supply of blood to the heart. It's quite interesting.
It's quite interesting. It just start beating afterwards. Alsan, what is coronary artery bypassing? Sorry, coronary artery spasm. Sorry.
Coronary artery spasm. Okay, so the artery has these layers called the endothelium, the muscle layer, and then another layer, and that constitutes the whole artery. The muscle can be sensitive to stimulus and can go into what we call the narrowing. That's called the spasm, and by definition, this is like transient compromise in the flow and then restoration of the flow. And it could be a variety of reasons. Some people are sensitive to the coronary artery spasm. Sometimes when we work in the coronary artery with oil and balloon, we see a spasm. So it could be a variety of reasons.
Do they get angina?
But usually this can give you a transient compromise in flow, and because of that, one can get chest pain we call angina.
Angina. Oh, okay. That's quite interesting. So it's coronary artery spasm. Now, how is life after bypass surgery? Vivek, what would you like to say a little bit about it? We got
Fantastic.
3 minutes left.
All right.
There is a caller as well. I'm going to get the caller as well. We got 3 minutes left. Let's see what we can do with him. Hello, sir. Hello.
I spoke earlier. I had a question left which I couldn't complete.
If you could ask it quickly, we got 3 minutes left.
Okay. Although all the 4 bypass grafts are open, I still got chest pain time to time, and I have been hospital many times in last 20 years. And I was told recently that I've got which is called micro. Small vessels are blocked, and that's why nothing could be done except medication.
So you had heart surgery.
And
yeah.
Whether anything can be done other than this.
Okay. So you had heart surgery, and it's all repaired. Now you still get chest pain, angina. Who's best person to answer for this question? We can ask the surgeon, or we can ask the cardiologist.
Chaudhary probably.
I think Chaudhary probably.
Okay,
So the
awesome.
macrovascular, the macrovascular means that the vessels that we can take care by balloon angioplasty stent, but microvasculars are like really very minute vessels, and then we cannot do anything much in terms of mechanical intervention, where we use the pharmacological intervention and those drugs that dilates, and addressing this will be like nitroglycerin, addressing this will be calcium channel blockers, potassium channel openers, all these that address the microvasculature. Sometimes people use those that changes the metabolism, like alteration in the metabolism. We use ranolazine also, but these are all the pharmacological agents that we use for the microvascular. There is also a good paper on the preconditioning. That means that you get this and then you actually precondition and you actually increase your exercise tolerance.
Okay, thank you very much. We're running out of time. Sir, you can always email us, or you can always send a message on Facebook or Twitter, and we will answer more in detail about your question. I can always ask my guest speakers, and they will be more than happy to answer. We are running out of time. Let's quickly say, what's life after bypass surgery? Vivek, would you like to say something about it?
I think most people would find that they benefit. It does take some time to recover from a major operation as a bypass. So it takes somewhere between 2 and 3 months for most people. Some people may need up to 6 months to get back to their feet properly. But most people would then find that they're able to do much more. Their risk of heart attacks is lower. It doesn't mean that they're off their medications. The surgery is helped by medication. So yes, unfortunately, the medications carry on as well. But that is how most people, active working people, should get back to their work style. And most people would actually find benefit. So, and people are unrestricted once they recover from the operation. So most people should be back to their normal self and be able to carry on with their life.
That's great. Thank you very much. Thank you very much, especially Shakil. He's a consultant cardiothoracic surgeon who joined us from Oxford, and Vivek also from Oxford, and Asan from USA. It's amazing to be with you. I wish I had more time and we could have talked more about, and unfortunately we ran out of time. And Hargo, it's amazing to have you in the studio. Are you happy with us?
Yes,
the program?
Thank you so much.
Yeah, and really thank you very much for being with us. I'll see you. Maybe we'll meet up in some other program. So, so far today we talked about ischemic heart disease and coronary artery bypass. It's a special subject. We didn't have much time, but we somehow gone through the majority of the stuff which you need to know. But you can always check in the NHS website for more details, or you can always ask us questions on our Facebook link or on our Twitter, or you could email us on healthtalk@iron.co.uk. And it was really nice having you all here. Thank you for staying with us on Iron's Health Talk with Dr. Akram. If you have any further questions, please email us healthtalk@irntv.co.uk. Don't forget that. And Facebook and Twitter, you can always follow me. And it's really nice having you all here. And until I see you next time, look after yourselves. Goodbye.